Professor Münir Stanröver from Ankara, Turkey, and I'm affiliated with Hacettepe University, Faculty of Medicine, Department of Internal Medicine, and also with the Vaccine Institute of the Department of Immunization Policies. So I will start with an everyday case in the emergency room. This is Mrs. A, and she is one of the hundreds of patients that we encounter in the emergency departments every day. A 79-year-old female patient presenting with difficulty in breathing, cough, increase in sputum. And when we dive into the medical history, we see that she has chronic obstructive pulmonary disease for 6 years and also have the comorbidities of hypertension, heart failure, and she's been operated for colon cancer. She's dependent for housework and mainly restricted to in-house activities. She says that she has been admitted to the emergency room 3 times in the past year with acute exacerbations, and she reports a very recent admission to the intensive care unit. She uses oxygen concentrator, home nebulizer, and mechanical ventilation support device. During the hospital stay, we have started systemic methylprednisolone and just adjusted her inhaler therapy and put her on non-invasive mechanical ventilation. And as we have started methylprednisolone, diabetes mellitus just evolved, and we have put her on insulin therapy. And due to the recent hospitalization in the intensive care unit, we have started an extended spectrum antibiotic piperacin tazobactam, but her respiratory failure was imminent, so we have transferred her to the intensive care unit. And the results of the cultures that we have gathered from the sputum and blood revealed Streptococcus pneumonia. And she has been treated in the hospital for 15 days. And on the day that she would be discharged, she said that she had an increase in cough. And we just took some examples and sent her home. And afterwards, it turned out that she has a coronavirus infection as well. And she has been hospitalized again after 3 days. So just looking at this catastrophic history of just one patient, we can see what if she would be vaccinated against Streptococcus pneumonia, because when we have looked at the medical records of the patient, we have seen that she was only vaccinated against COVID-19, but not for pneumococcal infections, not for influenza, and she has not received any tetanus, diphtheria, and acellular pertussis vaccination. The life of Mrs. A will never be the same. Not only her life, her caregivers, her family's lives will be changing ever and ever. She's been admitted to the hospital. And from the macro perspective, we can say that hundreds or thousands of patients like Mrs. A are admitted to the hospital, and this has a huge impact on the society and on the healthcare system. So actually, these infectious diseases put patients into a vicious cycle. Just giving the example of the chronic lung disease, we know that every infection may cause a hospital admission, and every hospital admission means a loss of functional capacity. It's the functional capacity of the lung, it's the functional capacity of the muscles, and also the cognitive functions. And each time the patient is discharged home, if we can, the patient is discharged with a more severe disease, making him or her more vulnerable to future infections. So it means that more dyspnea, more reduced exercise capacity, greater likelihood of becoming oxygen and housebound, and greater decline in health status and quality of life, and being dependent more and more on the others. So today we will be discussing about the benefits of vaccines beyond acute infection and disease and mortality, because we know that actually vaccine preventable disease in adults have many different aspects of burden. So we are talking about the functional decline, disability, impacted quality of life, and we can spend hours to talk about the antimicrobial resistance, which is a real public health threat of this century. So we are talking about the micro and macroeconomic consequences, loss of workforce, and utilization of healthcare services, given the already overwhelmed healthcare workforce and the services. So we know that the average of like 400,000 respiratory deaths, excess deaths, are associated with influenza globally each year. And unfortunately, of these, nearly 70% are deaths above 65 years of age. So older people are more prone to infections and the consequences of these infections. And we know that even the patient just survived that episode, recovery takes time, and sometimes recovery is incomplete. We can say that depending on the results of a cohort study from Canada, so patients interviewed over 65 years of age just reported that after an influenza episode, 21.5% reported poor health and function during recovery, and 3% admitted that they have never recovered. And given the background that like up to 20% of all adults experience an influenza episode each year, this is a huge number. So we know that the burden is just beyond the mortality and the acute infection is huge. And this mortality is sometimes partly attributable to the inflammatory processes that these respiratory diseases evoke. Like you can see here, not only influenza, but other respiratory viruses and Streptococcus pneumonia really trigger an inflammatory response that end up in myocardial infarction, cardiovascular diseases, and even stroke, some cerebrovascular events. And this risk is very much increased, especially in the first month and specifically at the first 3 days. Here you can see that after a Streptococcus pneumonia diagnosis, a patient has a 20 times increase of myocardial infarction, and this is huge. So just expanding our perspective from the respiratory infections, I also want to ask you the question, the terminology of communicable disease of childhood is still applicable? I must admit that it's no, because when you look at the seroprevalence data and also the burden of disease data, you can see that the once accepted disease of childhood, like tetanus, diphtheria, pertussis, and measles, are now affecting adults much more than the children. And this is the graphic from the just pertaining to the results of a study from our outpatient clinic. We have just looked at the seropositivity rate of certain diseases among adults, just ranging from 18 years to 95 years. And we have seen that 90% of the adults that we have surveyed had negative antibodies against pertussis. So they are prone to pertussis infection in the adulthood. So we know that pertussis is maybe a deadly disease for infants, for newborns, but what about the adults? So again, depending on the results of a surveillance study from a cohort of inpatients and outpatients in our hospital, I can say that pertussis prevalence was 3.5% among adults presenting with acute cough disease. And sometimes these patients may really present with devastating conditions, like given this case, a 66-year female patient presenting with 15 days of cough with paroxysms and vomiting after cough, disturbance of sleep and daily activities. And she had gastric cancer and was admitted to the intensive care unit with massive gastrointestinal bleeding, and she died in the hospital. And we would never know that she had pertussis disease if we didn't do that surveillance study. So the burden of the diseases are much more extensive beyond the current surveillance data we have in hand. And we should also put some focus on herpes zoster, because the lifetime risk of shingles is very high, and shingles is a disease causing post-herpetic neuralgia, but it may also trigger stroke, and it may be devastating and deadly in especially patients above 70 years of age. And it's not only the patient affected by the infection, but also the ones around the patient and also inside the patient can be affected, like the fetus or the babies of the mothers infected with influenza may develop severe congenital anomalies, neural tube defects, and hydrocephalus if the mother experiences influenza during the pregnancy. So we can say that there are many things to talk about the vaccine preventable diseases, and we need to define our aim. Do we want to live longer, or do we want to live healthier? And do we aim to add years to life or life to years? I think the answer is living healthier and longer lives and adding life to years. So where does the vaccine stand in this point of view? So we can just simply summarize the benefits of vaccination to protect beyond acute infection. like prevention of severe disease, complications, and acute exacerbations. But more than that, we can protect the unvaccinated population by vaccinating the community. We can prevent some related diseases and even cancer. And there are lots of societal benefits with vaccination, like ensuring the savings for a person and the society, and ensuring the economical growth, preventing development of antibiotic resistance, extending the life expectancy, ensuring safe travel and mobility that we have experienced during COVID-19, and also enhancing acuity. And just to give you some results about the big cohort studies on the benefits of influenza vaccination, here we can see that in a big cohort of type 2 diabetes patients, influenza vaccination resulted in a 30% risk reduction of stroke and 22% risk reduction of heart failure, beyond the benefits of protecting from pneumonia and influenza. And also giving another example from influenza, this is a randomized controlled trial very recently reported. You can see here that patients who have been vaccinated before discharge, who had undergone some kind of percutaneous coronary intervention for myocardial infarction, influenza vaccination reduced the risk of death from all causes, myocardial infarction, and stent thrombosis by 28% during a follow-up of 1 year. The cohort of healthy people, you can see that just vaccinating people with influenza vaccination can reduce the risk of first cardiovascular events, and also the risk of first cerebrovascular events and associated cerebrovascular diseases. Here you can see the results of a study including over 4 million adults followed up for 10 years, and you can see that influenza vaccination decreases the incidence of stroke in the following 6 months by 22%. And if you just compare these results with the benefits of, for example, statin therapy with the benefits of acetylsalicylic acid therapy, this is really remarkable. And another cohort of patients who have chronic obstructive pulmonary disease, again, here you can see that during a long follow-up for 11 years, there was a lower instance of stroke in those who received flu vaccination. And the good news is that if you just have it as a habit, like the vaccination habit, the protection increases with the increasing number of vaccinations. And there has been a recent hot topic on the prevention of neurocognitive decline with the vaccination, and this depends on the just the observation of the benefits of vaccinations with diphtheria, tetanus, poliomyelitis, and influenza to protect against the development of Alzheimer's disease. And now there are many studies, including prospective cohorts and also big databases. And here you can see the results of two examples here. So in one cohort of patients with chronic kidney disease, influenza vaccination reduced the dementia risk prominently, and it was again a dose-dependent reduction, and the vaccine effectiveness was greater in the more elderly patients over 70 years of age. And another cohort here again says you that if you can just vaccinate 29 people with influenza vaccination, you can prevent one Alzheimer's disease. And this is, I think, a very remarkable point to just work more, because there are not proven protective or therapeutic agents against Alzheimer's, but you can see that you may have the chance to prevent some Alzheimer's cases with influenza vaccination. And again, just focusing on the sequelae or the complications of herpes zoster infection, the shingles infection. We can see that in the first years following the implementation of a vaccination program in England, the incidence of post-herpetic neuralgia fell by 50%. And this risk reduction was also evident for the prevention of the ischemic stroke and the hemorrhagic stroke. And here you can see that over 1.6 million people aged more than 66 years who received live zoster vaccination, just the results show us that like 12% reduced risk of instant hemorrhagic stroke and 17% risk of instant acute hemorrhagic stroke. And this prevention is very remarkable after zoster vaccination. And it's not only the disease, but we can also prevent some cancers. And human papillomavirus is a known virus for causing cervical cancer among women. And here you can see the data from a big Swedish cohort who were vaccinated with the human papillomavirus vaccine. And you can see that if we can vaccinate girls before the age of 17, we can decrease the cervical cancer risk by 88%. Even those vaccinated between the ages of 17 and 30 have a 50% decreased risk for cervical cancer. So maybe you can eradicate the cancer just by just by using the vaccination as a community public health tool. And just vaccinating the pregnant, again, you can protect the baby. And here you can see again some remarkable results by vaccinating the pregnant women with pertussis vaccines and influenza vaccination. You can see that you can just succeed to reduce the preterm birth by 22% by the pertussis vaccination, and you can prevent the stillbirths by 45% by vaccinating the pregnant by the influenza vaccination.